Good morning, everyone. Today I'll be talking about the sound of silence. I'll be presenting on behalf of Medicine One. Presenting Mr. H. He's a 58-year-old gentleman from Arcot. He presented with history of tremors of both the hands for 2 months, decreased food intake and water intake for 1 week, drowsiness and decreased verbalizing for 3 days, and high-grade fever for 1 day. So this patient is a known case of bipolar disorder for the last 35 years. In the past, his symptoms are quite severe that he required electroconvulsive therapy. And after that, he was started on lithium 400 mg OD. A few years ago, because he was doing better, he discontinued his medication. And within a year, his symptoms recurred. So he was restarted on his old medication. However, over the last 2 years, although he was prescribed 400 mg OD of lithium, he has been taking 800 mg accidentally. And the other thing to note is that over the last 2 years, he developed bilateral osteoarthritis, and he had severe knee pain. And over the last 3 months, he's been going to the local clinics multiple times, getting NSAIDs and IM injections. And 3 months ago also, he had gone to an outside psychiatrist where he was started on olanzapine. We don't know the indication for starting on the same. Otherwise, he is a known case of diabetes and hypertension, and it was well controlled.
Just stop at this point. What's the diagnosis from the PGs? I think she's already given you the diagnosis. Anyone who's not from Medicine One, please give the answer. Lithium toxicity. How will you confirm the diagnosis? Okay, go ahead.
So when he presented to our ED, this patient was febrile. He had a core temperature of 103 to 104 that was fluctuating. He was tachycardic with a pulse rate of 120. And the only other thing was that in CNS examination, his sensorium was low. His GCS was 10/15. He was agitated, had coarse tremors, and on examination of his tone, he had rigidity. So at this point of time,
stop at that point. What's your diagnosis now? Anything new you're thinking of? Which month did he come in?
He came in October.
October. What do you think the fever is due to?
So our first differential, as we already discussed, is lithium toxicity, considering the patient has been taking a higher dose of what was prescribed.
How much olanzapine was he on?
Olanzapine, we don't know the dose. He only had a prescription. He had stopped it by the time he had come here. We don't know the indication also of taking. Our second differential was a neural malignant syndrome, because the patient was on antipsychotics, and he had history of high-grade fever along with rigidity. A close differential of that would be serotonin syndrome. And since the patient presented with history of fever and altered sensorium, we also considered CNS infections.
Was he on an SSRI?
Sorry, no, he wasn't. When he had presented to us, these were his initial investigations. There was no elevated counts. However, he had an AKI. His creat was 2.14 with a urea of 147. He had elevated lithium levels, so 2.46 with a CPK of 1221. Since he had history of fever and altered sensorium and we suspected CNS infection, we went ahead and did an MRI brain with contrast that did not show any features of leptomeningeal enhancement, no features of raised ICP. There was no features of any demyelination, cerebral volume loss. His CSF was bland, and this was his ECG. We did an ECG because we suspected lithium toxicity, and it did not show any sinus arrhythmias, any bradycardias, or conduction defects. A few days later, we also went ahead and did an EEG because the sensorium did not improve, which showed frontal intermittent rhythmic delta activity. So this is classically seen in any patient with metabolic encephalopathy, hypoxic encephalopathy, and certain neurodegenerative diseases. So during the stay, our patient did not have any indications for dialysis. So we treated him with aggressive hydration. However, even after, so here you can see that by day 5, his lithium levels had normalized. His creatinine levels also had come down, but his sensorium did not improve. So at this point, what did our patient have? So I'll come to it. So before coming to what our patient had, just a briefly about lithium. So lithium has been used for many years for bipolar disorder. Its effects are in many levels. So it can affect the mood. It decreases mania, it decreases depression. So it causes a relative mood stability. And at the level of macrostructure, it also causes increase in gray matter volume. So one of the findings that they have found in bipolar disorder is that there is a loss of gray matter volume. So lithium reverses that. That is why even though there is a lot of chance of toxicity, it's still being used up even now. At the level of neurotransmitters, it causes increase in inhibitory neurotransmission like GABA, and it decreases excitatory neurotransmission like glutamate and dopamine. So that causes a stability. And at the cellular levels, it prevents apoptosis and also oxidative damage. So how do we classify toxicity? It's based on the temporality. It can be classified as acute, acute on chronic, as well as chronic. In acute toxicity, GI symptoms predominate. In acute on chronic, there is both GI and CNS. And in chronic, there is CNS symptoms which predominate more. So this is again a picture showing the same. In an acute overdose of lithium, there is negligible lithium levels in the blood because the patient is previously not on lithium. So when there is an acute toxicity, there is a sudden increase in the plasma lithium levels. And this causes the GI symptoms. Lithium takes a longer time to permeate through the blood-brain barrier. So there is less likely that the patient will present with neurological symptoms in an acute poisoning. In an acute on chronic lithium overdose, the patient has already been on lithium tablets. So there is already a significant baseline lithium levels. And when there is some acute stress, like when the patient has an AKI, there is poor oral intake, diarrhea, loose stools, or even if the patient has taken NSAIDs and other diuretics, there can be a sudden increase in the plasma lithium levels. So here in these patients, they have both GI as well as CNS symptoms. And finally, coming to chronic poisoning, again, similar to acute on chronic, the patient is already on lithium tablets. So there is a baseline lithium levels present in the serum, in the plasma. And then there is, again, because of all these factors, they can have an increase in the lithium levels in the blood. And these patients present more with CNS manifestations. So classically, these are what the patient presents with. They can present with coarse tremors. They can have nephrogenic.
Did he have cerebellar signs?
He did not. We could not assess because his sensorium was low. Renal, they can present with nephrogenic diabetes insipidus, and they can also have sinus arrhythmias, conduction blocks, and GI symptoms include nausea, vomiting, and loose stools. So what did our patient have? Our patient is a patient who has been on lithium tablets for a very long time. And over the last 3 months, he has taken NSAIDs from outside. So that is why he probably would have presented with acute on chronic toxicity. Now that I've covered all the classic presentations of lithium toxicity, I would like to touch upon a more rare presentation. And this is called silent. So what is silent? Silent is a syndrome of irreversible lithium effectuated neurotoxicity. So what is it? Basically, some patients, they have prolonged neurological symptoms even after 2 months of stopping lithium medications. And these symptoms, some studies have shown that they can persist even up to 5 years of stopping the lithium medications. And these are more seen in chronic and acute on chronic toxicity as compared to acute poisoning. So how do these patients present? There are typical symptoms and there are atypical symptoms. The typical symptoms include cerebellar impairment. They can have extrapyramidal symptoms, dementia, seizures, and coma. Whereas atypical or the more rare forms, they have a downbeat nystagmus. They can have retrobulbar optic neuritis. They can have papilledema, choriothetoid movements, peripheral neuropathy, myopathy, or blindness. So since it's rare, there are only few case reports about this. So this is a case report about a 57-year-old war veteran from Filipino. So he's a Filipino who had history of bipolar disorder as well as PTSD. He had also presented like our patient. He had presented with almost 3 months of poor oral intake and a week of decreased sensorium and seizures. So at presentation, his lithium levels were 2.8. And since he had seizures, it was an indication for dialysis. He underwent almost 6 sessions of dialysis and his lithium levels had dropped to normal levels. But even after that, beyond 2 months, his neurological symptoms persisted. So this is how silent syndrome presents. So why do some patients get silent syndrome? There are a few mechanisms that have been proposed. One is demyelination of the CNS, cerebellar atrophy, loss of Purkinje cells, and also gliosis of the cerebellar cortex. So what are the risk factors? Fever. Why fever predisposes people to get silent is because they can increase the permeability of the blood-brain barrier. Concomitant use of antipsychotics, antidepressants.
Tephilah, I think you should close in 2-3 minutes.
Yes.
Because you're
Heart failure. So what did our patient have? Our patient had fever. When he had presented, his temperature was 103, 104, and he also had concomitant use of olanzapine. So this is what pushed the patient into silent. So what is classically seen in imaging is that they can have cerebellar atrophy, cerebellar volume loss. So this is a case report which shows that in a PET CT, we can see that there is a decreased uptake in the cerebellar area and basal ganglia. And in the diffusion tensor imaging of the MRI, there is disruption of the subcortical fibers. So how do we treat it? There is no treatment for silent. All we have to do is give them good physical rehabilitation, speech therapy, and cognitive training. So what did we do for our patient? He was admitted under us for 2 weeks. There was no improvement in GCS. So we had started rehabilitation in the hospital and we have discharged him. He's planned for close follow-up. So if there's no improvement in 2 months, we will do an MRI or a PET brain. So the learning points of this presentation are the spectrum of lithium toxicity and silent.
any questions? I have a question. What did you figure the fever was due to? Did he have NMS also?
We treated it for an NMS. We're not very sure, but we treated with hydration and we didn't.
Settled down?
He settled down.
Stop the olanzapine?
We stopped the olanzapine. CPK also came down.
He had an MRI brain?
He had an MRI brain contrast.